It's bedtime. The house is finally quiet. The dishes are washed, the toys are packed away, and as you're about to collapse onto the couch, you hear a sound coming up from your son's bedroom. Is it a raspy sound? Or perhaps it's a little bit wheezy. Your heart races a little bit. Should I act now? Is it one of those that I should ignore and deal with in the morning? Today we are going to unpack the kinds of sounds that children make when they breathe. The ones to ignore, the ones to keep an eye out on, and the ones that need you to take action now. This episode matters because breathing sounds can be one of the earliest signs that tell us that something is not right. In children, breathing problems can have a big impact on growth, health, and even heart health. I'm not here to make you feel paranoid. I want you to know the difference between the sounds that we should be worried about and the ones that will just go away. We'll be joined shortly by Dr. Lumata, an ear, nose, and throat specialist who's been helping little children breathe for years. But before we dive into that conversation, so snoring is a low vibrational sound that typically comes from the upper airway, like the nasal passages. Although it's common in adults, in children, it can be a sign of enlarged tonsils or adenoids, or even something as simple as nasal congestion. Stridor, on the other hand, is a more high-pitched sound that comes from lower down in the airway, either the windpipe or the trachea or the larynx, also known as the vocal cords. A wheeze is a more musical sound that comes from the lower part of the airway that can tell us about acute or chronic reasons why the lower airway is obstructed. Did I get that correct, Dr. Lumata?
No, that was outstanding. You defined it according to as we've been taught.
Thank you so much.
Thank you for inviting me to your podcast.
Thank you so much for joining us. I'm so excited to have this conversation because I think it's such an important thing in our community where we are seeing so much of this. Why do children snore?
Good question. And I think the way we need to unpack it is snoring normal? And the answer is no. Because snoring is an indication of an obstruction into your airflow. So generally, how we breathe, the nose has been designed to be a passageway for air. There's ought to be a smooth passageway for air from the nasal cavities into the back of the throat, down into your larynx, into the lungs. If there's any form of obstruction in your upper airway, then you would snore. The commonest culprits in the pediatric population is enlarged adenoids, tonsils, nasal congestion, as you had mentioned, allergic rhinitis, and then there's other rare causes that one can look into. But I think for this conversation, really, we need to establish the importance of addressing adenoids, tonsils, allergies, because those are the most common.
Okay, all right. So you've clarified to me that basically snoring is never harmless. I often hear people say, no, he snores because his dad snores, and people think it's a genetic thing that's passed down or it's a positional thing. So you're saying that snoring is never harmless and it's always something that should be taken seriously.
It should be. And it should be thoroughly assessed. Kids can snore, but with everyone. We can snore occasionally because of position. When we're in a recumbent position, lying down, our airway collapses, all right? During an acute episode of a flu, upper respiratory tract infection, you do snore, all right? However, it becomes a problem if it's habitual, meaning that if a child snores about 3 to 4 nights in a week, that is habitual snoring, it needs to be attended to.
So even if it's positional, even if they change position and it goes away?
Well, if they change position, it goes away, then, but it's always good for a child to be assessed either by a pediatrician or by an ENT surgeon so that we can establish if there isn't a sleep-disordered breathing. I think that becomes important.
What is that? What is sleep-disordered breathing?
So sleep-disordered breathing is a spectrum.
Okay.
All right? It ranges from primary snoring to upper airway resistance syndrome, to hypoventilation syndrome, and the most severe form is obstructive sleep apnea, where now the child completely ceases breathing. They've got fragmented sleep patterns, and we know that with that kind of severity, It can affect their neurocognitive development. It's got the effects in their cardiovascular health. So yeah, I think it's always better for if you see snoring that is habitual or that you're unclear of, to better consult a pediatrician or an ENT surgeon or some sleep centers.
And such an important point you've touched upon, because we often see cases of ADHD, cases of children with conduct disorders that are just labeled as naughty at school, and children who don't grow well. And when you further prompt the history, you learn that this child's been snoring for a really long time. So definitely, I think the sleep disordered breathing is a big part of
this. It is,
this.
because parents should remember that neurocognitive development, it occurs during the REM stage of sleep. Now, if that is interrupted frequently by these fragmented sleeping patterns, frequent arousals, that doesn't develop. Now, a child ends up with poor cognitive development, ADHD, conduct disorder, and as I correctly mentioned.
Okay, so basically we've spoken about symptoms at night, right? So we're talking about snoring, which you're mainly going to see at night. Can enlarged adenoids, tonsils, etc. cause other symptoms maybe that are more present during the day?
Yeah. So, yes, one should also observe how the child is breathing at rest. If child breathes with their mouth open, it's a form of compensation that the nasal cavity, pass the airflow through the nasal cavity to the back is obstructed. So they compensate by opening their mouth to breathe. So open mouth breathing, congestion, nasal congestion, snotty, if they're snotty all day and they're blowing their nose frequently, then those, and if they've got a stertorous breathing, a stertor is, it's almost like it's low-pitched, and it's a sound that comes from nasal cavities to the nasopharynx. So if there's also that abnormal sound, so those are symptoms that one needs to watch for during the day, and at night then you look for obvious open mouth breathing still, snoring, and you must observe if the child stops to breathe, if there's increased respiratory effort, if there's labored breathing, and if they've got when they're sleeping they do this so that kind of fragmented sleep, things that they should watch for, parents should watch for at night. Also, because adenoids are in close proximity to a eustachian tube, sorry to go into deep medical jargon, because they're in close proximity to a tube that connects to the middle ear. Children can actually also get hearing problems, be in the form of hearing loss, speech delay, ear infections and so it's quite one needs to be comprehensive when it comes to assessing these kids, and also parents observing their development, speech, hearing.
You mentioned allergic rhinitis a little bit earlier, and I'm hearing it kind of come through again. Can you give us a word on allergic rhinitis? How do we know that it's allergic rhinitis?
Good. So you look for symptoms like, is the child congested? Do they have watery rhinorrhea? Is it watery nasal?
Nasal discharge.
And if they are frequently itchy, scratching their nose, scratching their ears, that sound is an indication, all right? And then when you check their nose, you will see, I'm just going to take my human scalp, So if you can check with allergic rhinitis, so if you open up like this, all right, close like this, in the midline is the nasal septum, all right, it's a wall that divides the nose into right and left, you can see, all right, and then on the sides it turbinates, all right, so if you close it like this, if that sides on, if this part of the anatomy is enlarged, red or pale, boggy, that is indicative of allergic rhinitis. Okay, and generally there's tests that we do to look for allergic response either in blood or local allergy tests and all right. But sometimes symptoms really are enough to make a diagnosis. Okay.
Allergic rhinitis is quite common, am I correct? We see quite a lot of it actually with our air pollution being the way that it is, and possibly with a big family history component as well.
And it's one of the problems because some kids, even if you can remove their tonsils and adenoids, if the allergic rhinitis is not well controlled, they will still exhibit symptoms of obstructive sleep apnea. So it's very important really to attend to all precipitating or contributing factors.
Okay. All right. Okay, back to snoring.
Okay.
Are there common myths that you'd like to bust? What are the things that you hear frequently? I mean, we mentioned the genetic component. We mentioned the child's dad snores, so therefore the child is allowed to snore.
Some have practice of like, no, the child will grow out of it. You know, and I think it becomes dangerous now because if they don't, or you delay until they're in their teenage years and the damage has been done, you know? And some of the myths I've actually heard is, no, it's pointless to do the surgery because tonsils can always grow back. This I heard this past weekend, I tell you, I kid you not.
I've heard it before, yeah.
My brother had a tonsillectomy 3 times. I'm like, what? 3 times? So that also discourages people from seeking medical health, so...
It's difficult, and I think platforms like this are important because we start to kind of debulk some of those myths by giving proper information, right? Because I think information is everywhere, but not necessarily in the correct places. So when you see a child, what is the process? So let's say my child has started snoring. I would like to come and see Dr. Lumata because I'm worried about my child and I've now watched this episode. What is the process?
So do you mean in terms of me tracking the patient?
Yeah, no, like that. Like what do they go through? So they come in. You in terms of the examination.
Good, very good. So would encourage parents really to make use of their phones and take videos because that would give me 80% of the information I need, right? But generally we would start by asking, is the child snoring? Is it loud? Have you witnessed episodes where the child stops breathing? Is there labored breathing? Do they breathe with their mouth open? All right. Is the nose blocked? Are they snorting? Are there any hearing problems? What's the speech development of this child? You know, have you witnessed or seen any ear discharges? Okay. Do they have crooked teeth? Because, you know, with open mouth breathing, in a long time, it does affect the anatomy of the face. And that's why there's what we call adenoid faces. You know, kids get this long, narrow face because maxillary and mandibular development gets affected by open or by this chronic mouth breathing. Right? Okay. So those are all the questions that we would ask. All right. And thereafter, we then proceed to examination. So with examination, we examine the upper airway, starting from the mouth. We look, is the tongue the correct size or is it too big? Is there overcrowding in the mouth? How are the tonsils? We grade the tonsils. Grade 1 being the smallest, grade 4 being the biggest. Right. And then we generally also put in a camera. I put in a camera in the kid's nose so that I could see, is there patency in the nasal cavities? All right. Are there any structural abnormalities? Is the septum straight? Is it deviated? I proceed back to the back of the nose in the post-nasal space. I look for an adenoid tissue. I measure it in relation to the surrounding structures. What's the percentage? Is it 60% obstructive, 90%, 10%? Right. And then further down into the base of tongue, and then I go into the larynx because, you know, kids who've got laryngomalacia, abnormalities of the larynx, they can also exhibit symptoms of the obstructive sleep apnea. All right. So that's what I do. And then once I've identified the problem, of which in 70-80% of the times it's enlarged adenoids and tonsils, then we book, you know, you counsel the family, you counsel the parents, and you encourage them really on doing EE surgery because the first line treatment for obstructive sleep apnea that's secondary to adenoids and tonsils is surgery. All right. And we've advanced in surgery, to be honest. We've really advanced. Unlike before, where we used to do cold still or do electrocautery and kids would be complaining of pain, we now use coblator. There's quicker recovery, short hospital stay, less pain.
What's coblator? You just...
Good, sorry. So coblator is an instrument that we use to remove tonsils and also to ablate the adenoids. All right. So it's just a single instrument that ablates, it coagulates, it also suctions.
Okay.
So removing a tonsil is quicker.
Okay. So it removes them and sucks them out, basically.
Yes.
Okay.
Yeah.
All right. Sounds better than what it sounded like before. Now, a lot of patients and parents are terrified of the idea of surgery, of adenoid surgery. I mean, if I go to a doctor, I'm seeing you for the first time, you're telling me, listen, we need to operate next week, I'd be terrified. And I completely get why there's sometimes some hesitancy around that. Are there non-surgical things that they can do to optimize snoring, to optimize the sleeping position, things like that, perhaps while we're thinking about or waiting for the surgery?
For the surgery. You know, unfortunately, there's been trials of intervention when it comes to snoring, obstructive sleep apnea. Some trials they've tried using intranasal steroids, corticosteroids, Flomist, Genemist. And unfortunately, the efficacy of that medicine, there isn't sufficient evidence really to say, no, this you can use as an alternative. All right?
Okay.
There has been some mandibular devices that have been proposed, and oral appliances, but to really think your child would go to bed with appliances and with CPAPs and things like that. You see? Yes, CPAP is it's a good device, all right? But it's more for adults. In kids, also don't want now a child to be subjected to having an oxygen mask at night, because that ultimately will affect the development of the face.
Yes.
You see? So surgery, really it's less than 30 minutes, it's quick. All right. Recovery, two main complications. It's pain and it's bleeding. But we do give pain meds for that. And after a week, generally kids, they do well. And plus also with coblation and with these new techniques, pain is not as severe. It's tolerable. Okay. And it responds to pain medicine. So it's a tonsillectomy is one of the most common operations performed worldwide. And the outcomes are remarkable. Okay. The outcomes are remarkable.
Okay. Okay, you seem to always put adenoidectomy and tonsillectomy together, right? Tonsils sit at the back of the throat, right? And sometimes when you're sick, you can feel your tonsils are enlarged and you open your mouth, and you can see it at the back of your throat, right? But adenoids are not as simple to see. So you mentioned that you need a special camera, right, to kind of look into the airway. And that's something my patients are often struggling with, struggling with understanding exactly where the adenoids are and why they can see the tonsils, but they can't see the adenoids, yet we insist that they are there, right? And things, I think, imaging, like x-rays tend to help. So often you just kind of see like a shadow where the adenoids are, and that kind of helps a little bit as well. But I noticed you use those terms together almost always.
Actually, thank you so much. Thank you very much for asking the question, because I've had cases where a parent would say, no, doc, just remove the adenoids and leave the tonsils. And I think it's because of what we read on Google or what they're exposed to. Maybe they've witnessed their neighbor's kid who had a tonsillectomy and they're struggling with pain and. But now, I'm going to dive in a bit into the physiology of sleep. So when air passes through the upper airway, it passes through the nasal cavities, passes through the postnasal space where there's adenoid, it passes through the oropharyngeal space, all right, where there is tonsils, all right. So you can get obstruction from many levels, all right. So in as much as an adenoid can be removed, if the tonsils are big and enlarged, they are forming or they're causing an obstruction in another passageway. So then the outcomes of just addressing adenoids would not be as remarkable. So that's why then we actually need to remove both the adenoid and the tonsil. The exception is when the child is less than 2 years. Generally, when the child is less than 2 years, we don't touch their tonsils because it confers some immunity. So we would spare them, but would remove adenoid. And yes, there would be improvement. All right. But after the age of 2 years, if it consists or it persists, then we can actually suggest a tonsillectomy.
Okay. So you're saying they enlarge together. When the adenoids get big, the tonsils
generally
get
because
bigger
they're part
as
of
well.
the same group of tissue. They're part of they're both lymphoid tissue, part of the Walder's ring. So generally, I've noticed that when adenoids are big, or when tonsils are big, adenoids also. All right. But the beauty about adenoids is after the age of 6, then they involute, they regress. All right. So you find that in an 8 or 10-year-old, it's possible that you might only have to do tonsils because the adenoid, there's no longer adenoid tissue. But in kids who are really struggling with breathing, snoring, apneic attacks, then adenoids and tonsils both must come out.
Okay.
Yeah.
You mentioned something in passing. You said the thing about tonsils confer an immune benefit in small children. And again, that's another reason where often parents are hesitant to have any sort of tonsillar or adenoidal surgery because isn't it part of the immune system? Why are you telling me I need to remove a part of his immune system? Is he not going to be more susceptible to infections and things like that? What do you say to that?
Risk-benefit ratio. So we need to look at the benefit of removing your tonsils versus the risk of you having them and them conferring that immunity. Because also after the age of 2 years, 2 to 3 years, the immune system is fully developed. So the role that the tonsils have in the immune system is very small. It's very minimal. So that's why then we actually encourage that we have them removed rather than keeping them, your tonsils and adenoids, and then you're sick all the time. They're causing you ear infections, the speech delays, neurocognitive developmental delays, cardiovascular health. So one really needs to weigh the risk and benefit of keeping your tonsils versus removing them.
How I often describe it to my patients or explain it to my patients is like it's a part of your immune system that's doing too much, right? So yes, the fever is there to fight the infection, but sometimes the fever is too much, and that's why we need to bring it down with medication, right? So sometimes your tonsils are too large and they're getting too infected, and you have obstructive sleep apnea and a child that snores all the time. Then we think, okay, this immune system is doing too much and it needs some help. That's generally how I explain it to patients, that yes, it's a part of your immune system. So let's move on to Stridor, right? Which is a lot less understood. Snoring, everyone can identify snoring, but Stridor is a lot less understood, but actually pretty common.
Yeah, it is. It is. It is. So with Stridor is a sound like this. So it's more high-pitched. It comes from the larynx or from the windpipe. All right. Commonly, we see Stridor in neonates and infants, and the commonest cause of Stridor, again, you use a camera to check, is a condition which you call laryngomalacia. Most common congenital deformity of the larynx, where you get redundant of some tissues, arytenoid tissues in the larynx. Okay. It can come from the narrowing below the larynx, which you call subglottic stenosis. Which is a topic on its own. Okay. So it can also come from, so commonly in younger children, or let's say in infants, common cause is laryngomalacia, that deformity of the larynx. Okay. In older children, 2 things that one need to look for, especially if it's an acute onset. Child goes, they were playing outside, suddenly they come back with this sound. You go to ED immediately because we need to look for a foreign body. A commonest cause of acute Stridor in children is a foreign body.
Peanuts in children under the age of 3.
So if your child has sound, then suddenly there's this sound, you immediately go to casualty. Child needs to be assessed urgently. I've had a case whilst I was training at Steve Biko. Shame, child had an eggshell that was stuck on the glottis.
Sure.
I had to carry the child to theatre myself. I went into theatre unscrubbed. Now sisters were not impressed because everyone was running after me. But now after they witnessed good, this child actually can't breathe. And then urgently, it's not even, in as much as we call it an operation, urgently gets the child, open up, identified that object. It was an eggshell, literally sitting on the glottis. Then we removed it. That was life-saving.
Sure.
So stridor, high-pitched sound, acute, child must be assessed immediately. If it's chronic and it's associated with other symptoms like voice changes, if a child's voice starts becoming hoarse, and you see that they start having difficulties in breathing, and then that they start having that sound, then one needs to look for things like respiratory papillomatosis.
Okay.
All right.
Okay. What is that?
Also, so it's papillomas.
Okay.
You know how there's STI, genital papilloma.
Okay.
Yeah, and then this one, it develops in the larynx.
Sure. Okay.
So yeah, it blocks the airway.
Is that pretty common?
Relatively speaking, it is.
Okay.
Relatively speaking, it is not as common as snoring.
Yeah.
Not as common as laryngomalacia, but we do get kids really who come with recurrent respiratory papillomatosis. That time again we need to debulk. Severe cases is where now, if they're too obstructive and they occur at short intervals, that we then have to put in a tracheostomy, a pipe, just so that it helps them breathing. And again, we debulk. We don't have any adjuvant treatment that really has been proven to eradicate the disease. They just grow out of it.
Sure.
Yeah. Okay. But I think the lesson for this podcast, acute stridor in older children, ED, immediately we need to look for a foreign body. Other causes then would be subglottic stenosis and croup is actually croup is more common than the papillomas.
Yeah.
Than the respiratory papillomas.
Yeah. And that's basically a child who starts off with flu-like illness and then has what you call the barking cough, and then we hear the stridor. You see, the ENTs and the pediatricians have become very good at the sounds. Okay, all right, okay. So in terms of the stridor, we have kind of groups that are more at risk. I know our premature babies are at risk. Babies that have required some sort of airway intervention are at risk. Babies with reflux are at risk. Are there any other kind of groups that we should be worried about when we hear the sound and think, okay, it's probably from that?
I think it all needs to be individualized. Once there's a sound in the airway is abnormal. All right. Breathing should be silent. Once there's snoring, once there's stridor, once there's a wheeze, it needs medical attention. All right. So yes, premature because the larynx are underdeveloped could be laryngomalacia. It needs to be assessed because we need to decide: are we going to treat this conservatively, meaning we observe, give some PPI, or are we going to intervene where you do supraglottoplasty, release some folds, or you understand?
Yeah.
Is it if this child was admitted in ICU for long and they've subsequently developed a subglottic stenosis, do we dilate? All right. Or do you understand? So there's different intervention, or do you put in a tracheostomy? So that's why we generally recommend, if any patient for that matter, prolonged intubation in ICU, we need to put in a tracheostomy to prevent a long-term sequelae, of tracheal stenosis, which becomes more difficult to manage. So, yeah, it's a bit complex, but really it all needs to be individualized. Infants, neonates, infants, toddlers, older children, it all needs to be tailored down to the patient. In this group, what's the most common?
Yeah.
You understand?
Yeah.
In this group, croup is the most common. Come, let's give you some oxygen, let's give you some adrenaline nets.
Yeah.
Okay.
Yeah.
Unless in severe, really, and it's rare, there is severe cases of croup where we've had to do a tracheostomy.
Sure.
Yeah.
Yeah.
So yeah, I think the lesson really should be, if there's any sound in a child's airway, when the child is sleeping, it needs to be attended to by a pediatrician, by an ENT, by a GP.
Don't ignore sounds in the airway.
Do not ignore sounds in the airway.
Is there anything, so, as parents, we blame ourselves all the time. Everything happens and we're like, what could I have done to prevent it, right? Is there anything parents can do to prevent these sounds, to prevent snoring, to prevent stridor? Is there anything we can do? I know we've mentioned the role of allergic rhinitis and allergies, but is there anything that we can kind of do at home in terms of allergy prevention? In terms of sprays, I mean, I know you said that nasal sprays aren't really doing anything in the long term.
No, so nasal sprays are not doing anything for adenoids in particular.
Okay.
But please, for allergic rhinitis, perfect.
Okay.
So allergic rhinitis, we do use topical corticosteroids. You can use Flomist, it's cheap, you get it over the counter.
Okay.
You can use Genomist, you can use Beckley sprays. There's really different kinds of topical steroids that you can use, all right?
Okay.
So please, for allergic rhinitis, mainstay of treatment would be topical steroids, nasal sprays, all right?
Okay.
Adenoids and tonsils, that's surgery, unfortunately, right? Is there anything that parents can do to prevent? Yes, if parents need to consult, they need to consult with you, you're the pediatrician. If child exhibits symptoms of allergic rhinitis, you will do bloods that will enable us to identify what is it that this child is allergic to. You understand? If it's dust, if it's mold, then we can change furniture, remove carpets, and that's what parents can do.
Okay.
But
Except it's
they
very
can't do much
expensive
about
to
tonsil.
remove carpets.
It's expensive, huh?
It's very expensive to remove carpets. Okay. All right. I'm back at my myths because I think it's important to bust these myths. So let's bust some myths. Okay. If my child snores, they would grow out of it. True or false?
False.
Okay. Stridor only happens in croup.
False. No, false.
Tonsils should always be removed in a child who snores.
I'm not happy with always. It depends, man.
Okay.
It depends. You don't just remove tonsils for the sake of. There really should be an indication.
Okay.
So
In a
if
child
really
who
they're
snores.
in a child who snores.
Maybe,
because I mean, if snoring is severe and is associated with other symptoms of obstructive sleep apnea, certainly they need to be removed.
Okay.
And as I've said, snoring is not normal.
Yeah.
So if the child is snoring primarily because of tonsils, then yes, they need to come out.
All wheezing is asthma.
That's false.
Okay. So if there's one thing that you'd like parents to remember about what you've taught us today, what would that be?
Don't ignore sounds from the upper airway. Any sound you hear, you don't even have to understand. Take the child for consultation. Then you will help them. I can help them. Yeah. Any sound in the airway is not normal. They just need to be seen. And also, parents, they should actually also look into this part of the neck. If there's tugging, this is a sign of obstructed breathing. All right, so those are also the things that they need to look into. And also, we would really encourage them to use their phone so that they can show you. Dr. Sebetseba?
Yeah.
Because then you can actually then listen. You'd be able to determine: is this snoring? Is this stridor? Is this stertor? Is this a wheeze?
Yeah. No,
Okay.
I absolutely 80% of the time ask for videos, and that's how we're able to ascertain the cause of the airway obstruction. So absolutely 100%.
Sounds should not be ignored. I think that's it.
Thank you. Thank you so much.
Good.
So there you have it, guys. Breathing is something we take for granted, especially when it's normal. But as we heard today, no sounds in the airway should be ignored. Thank you so much to Dr. Lumata for joining me today. If you learned anything about snoring or wheezing or stridor today, I'd like you to share, subscribe, and drop a question in the comments. Remember, stay kind and stay curious.